This is a foundational topic in clinical cardiology. When approaching narrow complex tachycardia, also called narrow QRS tachycardia, defined as QRS duration less than 120 milliseconds with a rate more than 100 beats per minute. The diagnostic goal is to systematically differentiate between supraventricular tachycardias that utilize the AV node versus those that do not. Here is an advanced framework for differential diagnosis, moving from the systematic analysis of the rhythm strip to specific pathophysiological mechanisms. To effectively categorize a narrow complex or narrow QRS tachycardia, primary task is to identify the relationship between P wave and the QRS complex. RP interval is the time from the onset of the QRS to the next P wave, which is a powerful discriminator between short RP tachycardia, in which RP is less than PR, and long RP tachycardia, in which RP is more than PR. Short RP tachycardia examples are typical AV NRT. P waves are often buried in the QRS or appear as a pseudo R wave in V1 or pseudo S wave in the inferior leads. Next is AVRT, orthodromic AVRT. P waves are distinct, usually visible after the QRS, often in the ST segment. Orthodromic means conduction downwards is through the normal conduction system and retrograde conduction is through the axillary pathway. Moving to long RP tachycardia, in which RP interval is more than PR interval. Examples are atypical AV NRT, that is down the fast pathway and up the slow pathway, that is the reentrant circuit in the AV node. P waves are deeply inverted in inferior leads. Atrial tachycardia, P waves are generally distinct. PJRT, permanent junctional reciprocating tachycardia, a specific incessant form of AVRT with a very delayed retrograde P wave that will be inverted in inferior leads through a tortuous posteroseptal axillary pathway. Here is a diagnostic matrix for some supraventricular tachycardias. Typical AV NRT, P wave is buried in the QRS or there is pseudo R and pseudo S. It is regular and the mechanism is re-entry, slow, fast. Orthodromic AVRT, P wave is after the QRS, regular, and it is axillary pathway. Downward conduction is through normal pathway, that's why concealed. Axillary pathway is concealed in the tachycardia location. And atrial tachycardia, P waves are variable location, usually regular. Focal automaticity or macro re-entry are the mechanisms. Atrial flutter, instead of P waves, there are sawtooth flutter waves. Rhythm is regular usually. Mostly it is macro re-entry related to the isthmus. There are others as well. Atrial fibrillation, there are no P waves. Fibrillary waves may be seen. It is an irregular rhythm. Multiple re-entrant wavelet in the atria. In typical AV NRT, that is slow, fast, down the slow pathway, up the fast pathway. The retrograde P wave occurs almost simultaneously with the QRS because it is very fast conduction, retrograde. This creates a pseudo R deflection at the end of the QRS complex in lead V1. If you see this, you are likely looking at the slow fast re-entry loop at the AV node. Actually, you can call it as pseudo R prime. In inferior leads 2, 3 and AVF, the retrograde P wave in typical AV NRT often manifests as a pseudo S wave. This is a subtle distortion of the terminal part of the QRS. When evaluating a narrow complex tachycardia, always compare the terminal QRS morphology to a known sinus beat if available, that is a previous ECG with sinus rhythm. If you compare the terminal portion of the QRS, you can identify the difference. There are also situations in which a tachycardia of supraventricular origin can have wide QRS, antidromic AVRT. This will present as a wide complex tachycardia but is physiologically SVT. If the patient has a non-axillary pathway, always consider this even if the QRS is aberrant wide. Pre-existing bundle branch blocks also can manifest similarly, or transient bundle branch block during tachycardia. In atrial fibrillation, it is called Ashman phenomenon. An aberrant conduction caused by a sudden change in cycle length can mimic a ventricular rhythm. Aberrancy can be maintained for more cycles by concealed transseptal conduction and resemble a run of VT. If the ECG remains ambiguous in spite of meticulous evaluation, clinical maneuvers or pharmacological probes are diagnostic tools. Vagal maneuvers or adenosine. These are diagnostic probes. Termination. If the rhythm terminates, it confirms it is an AV node dependent tachycardia like AVNRT or AVRT. Transient block. If AV block occurs but the tachycardia continues, you are dealing with an atrial source like atrial tachycardia or flutter. Then esophageal ECG. If the surface ECG is non-diagnostic, esophageal leads can provide high fidelity visualization of atrial activity because left atrium is very near the esophagus, allowing for precise measurement of the VA interval.